Good morning, Peter Goertz. I'm a psychiatrist working in a psychiatric emergency room. So you see the whole human experience, the whole range there, and you see plenty of things that you may or may not expect, and you're going to be blindsided. You want to go into that area when you work there with as much as possible, a totally accepting attitude. You're going to see all different sides of humanity, and you want to embrace that and be non-judgmental and enjoy yourself working with all these different people from various walks of life. My first night working in a psychiatric emergency room, I was a junior resident, and the senior resident, a female senior resident, was in charge, and she was triaging the patients. And she would write down verbatim what each patient's chief complaint was coming into the emergency room. And the first patient I got, she wrote down verbatim, "I want to suck you, fuck you, eat your pussy." That was the chief complaint, written on paper in nice, clean handwriting. And I saw that, and that was my introduction to the psychiatric emergency room. So you're going to see a whole variety of patients, and pretty much anything can happen. I mentioned in another video a patient overdosed on his medication right in front of me in the emergency room. Another resident at the time, another junior resident at the time when I was just starting, told me a patient of his whom he'd seen previously, if I recall correctly, on a ward. He came into the emergency room all dressed in black leather with a dildo inserted in his rectum in a manic state. And you want to be in the emergency room setting, you want to focus on safety as the priority, safety of yourself, safety of the patient. And it's very important that security screen patients, check patients when they come in for anything that can be used as a weapon. So anything like a knife, firearm, syringe, a needle, anything they want to take away from the patients. And it's also important that, if at all possible, large male staff members are available to help you with the patients, because they do get agitated relatively frequently, especially if it's a big psychiatric emergency room. So just for psychiatric patients all in one area, there can be fights, people can start throwing things. I remember a patient walked into the nursing station one day and threw around the computer in the nursing station. So it can be pretty scary, and it is important to have large male staff around, staff members that can help around. You want to be very careful with your seating. So when you're evaluating a patient in the emergency room, in a psychiatric emergency room, you want to sit closer to the door if at all possible. So just in case the patient gets agitated, you can run out, get help. And back then, when I was a junior resident, if it was quiet in the emergency room at night, we were allowed to lie down and sleep on a stretcher. But the problem with that was, we were sleeping in an office on a stretcher, but right outside the office in the hallway, there were patients sleeping on stretchers. So anything could have happened. A patient could have walked into the office, assaulted anyone. So hopefully that type of thing is not happening anymore. The major question, or one major question when a patient walks into the emergency room, a psychiatric emergency room, is, does the patient need to be admitted or not? And in order to make that assessment, you want to look at various aspects. And another question that's major is, if the patient does need to be admitted to a hospital, does the patient need to be admitted to a psychiatric hospital or a medical ward in a hospital? So psychiatric ward or medical ward. That's also a key decision. For instance, if someone's confused, delirious, they don't know what day it is, where they are, more than likely they're going to need to be on a medical floor, not on a psychiatric floor, because more than likely some medical issue or medications are contributing to the patient's confusion. Could be a drug. So that kind of patient would benefit from a medical setting. You want to review previous records if at all possible, psychiatric and medical records, including outside medical records. Nowadays, the computer systems are pretty good. You can get access to even medical records in other cities, other hospital systems. And one key thing that it's important not to forget is to get collateral information, for instance, from a family member, girlfriend, child, because that can definitely reframe the whole situation. The patient may be denying any problem, saying everything's fine. The patient may be looking fine, may be calm, cooperative. But then the mother, when you call her, may say the patient tried to hang himself last night in the bathroom of their house. So if at all possible, it's a key thing to get collateral information, so additional information from a family member, friend, girlfriend. And it's important to do the physical part also, to evaluate the physical state of the patient by a physical exam, lab work, EKG, if necessary, an X-ray, CAT scan of the head. And if someone does get agitated, you want to try and make sure they don't get out of control. Make sure you keep them medicated if they are about to get out of control. And in general, we use Zyprexa orally or intramuscularly, or Haldol, Benadryl, Ativan, one or more of those three, orally or intramuscularly. And there are other options also. And if at all possible, you want to avoid restraints, but sometimes patients do need to be restrained. Thank you.